All right. Looks like we are in pretty good shape. So Patrick, I'm going to hand it over to you.
Great. So good morning, everybody. My name is Patrick Pluman. I'm the GM of Quest Business here on the West Coast. Thank you for choosing to share your Saturday morning with us and participate in the discussion around uncovering the hidden epidemic. I think it would be remiss if I didn't pause to briefly comment, reflect on last night's news of the passing of the extraordinary Justice Ruth Bader Ginsburg. She, as we all know, spent her life in the pursuit of a more equal world, first with her leadership as the director and litigator of the Women's Rights Project of the ACLU during the 70s, and then obviously later in her role as a Supreme Court Justice since 1993. What an extraordinary life, what an extraordinary contribution advocating for the guarantee of equal protection under the 14th Amendment. And it is a moment here as we reflect on her incredible life that she had. So turning to this morning, at Quest, we're committed to helping address the healthcare needs of the underserved communities in the area where we live, in the Bay Area. We've got a strong presence here from Quest Diagnostics, and we know these needs have been exacerbated by the COVID-19 pandemic, which has highlighted these long-standing issues of health inequalities across class, income, and racial lines. Early on in this pandemic, Dr. Diane Havlier, one of our panelists today, completed a study within the Mission District that found that infections were concentrated almost exclusively in low-income Latinx people working frontline jobs, where infection rates were nearly 20-fold higher in the Latinx population than the non-Latinx participants. And in fact, further afield, CDC reported African Americans are 2.6 times more likely to contract COVID-19 and nearly 5 times more likely to require hospitalization. CDC also reflects existing conditions like asthma, hypertension, obesity, chronic kidney disease are all more likely to lead to hospitalization during a COVID infection. And we know that these conditions are more prevalent in communities of color and low-income neighborhoods. So change is needed to help support these at-risk communities, and that change requires hard work and commitment from frontline organizations like PRC and the National AIDS Memorial, our neighborhood doctors, healthcare clinics, hospitals, local state governments who are coordinating efforts to fight the virus. And Quest is proud to partner with many of these operations who, like Quest, are committed to delivering better healthcare for all people, and we count on them to help us understand the needs of our communities we serve, which helps us make our collective impact go further. So today our discussion is focusing on some of these challenges that these organizations are seeing and dealing with every day on the ground. We're going to look at some of the similarities that this pandemic has with HIV pandemic, and we're going to expand our understanding of the current crisis and then end with some lessons that we've learned that we maybe all can implement in our role as caregivers in the communities we serve. So with that short introduction, I'd like to start to introduce our moderator, John Cunningham, Executive Director of the National AIDS Memorial, veteran in the war against HIV, a mentor, a promoter of community solutions that make a difference. John, over to you.
Thank you so much, Patrick. Welcome everybody to this morning's panel. I can say that I am indeed privileged to be able to moderate this. So many that are on this panel, both as individuals as well as organizations, are near and dear to my heart, having been either a client to many of these and or walked this journey together. As Patrick said, my name is John Cunningham. I'm the Executive Director of the National AIDS Memorial. For those that may not be aware, the National AIDS Memorial is located in Golden Gate Park. It has been there for nearly 30 years, and it is our nation's only federally designated memorial to AIDS. I think it's noteworthy as well. Last year, we completed the transition and stewardship of the AIDS Memorial quilt, returning it from Atlanta to San Francisco, Bay Area, where it now resides. So we have brought these two iconic pieces of history and memorialization back to continue to tell the story. I'd like to put a couple of pieces of housekeeping out there before I make a few remarks and then turn it over for introductions. You will notice in the navigation bar, either on the sidebar or at the bottom, there's a Q&A function. If you would like to pose questions to the panelists, you may do so during the discussion, and at the back end, when this is wrapped up, we will go through, and if the questions are still noteworthy and have not been already answered, we will do so. If you want to direct a question to a particular panelist, please make note of that in your questions so that we can ensure that we note them in that way. You know, it's so ironic. You know, I never thought that I would live through one pandemic, let alone now living through a second pandemic. As a memorial and as leading a memorial, you know, memorials are about memory, and memory is about never forgetting. And the way that we never forget is we continue to tell the stories. And in this case, we tell the stories of an epidemic. We tell the stories of social justice or injustice, community activism, research, and medical. And we also keep the stories of those that we've lost alive by telling their story. So today, I see as an opportunity with the rich history that is present on this panel to tell this story. When I was talking with Quest about the opportunity that they asked me to share, back in April, in the second week of April, I penned an op-ed. And I've extracted just a few pieces from that I think are relevant. And then I think it'll set us up, and then I'll turn it over. For those of us that have lived through and survived the horrific time of the early days of the AIDS crisis, we cannot help but to see parallels to the present day. And with great pain, we can't help but ask ourselves, what did we really learn from it all? As during the AIDS crisis, it is difficult to see politicians joke and stigmatize a disease, inciting fear and discrimination, putting our countless lives at greater risk, and doing nothing to reduce the health threat. As we knew then and know today, a virus does not discriminate against an ethnic group or a region of the world, and neither should we. It is unacceptable for our government to be caught off guard, as it was with AIDS, by the scope and severity of a pandemic coming to a health system unprepared and trying to grapple with solutions as we have for the last 40 years. It is also painful to watch in fear that our friends and loved ones will not get sick, and we hope that on a daily basis. As we know, there is not a cure yet on the horizon. There is only hope that something will happen, and we will take action. We know the HIV community and communities of color, along with the elderly and people living with contributing medical cofactors, are at greater risk from the virus, ensuring that the health of these populations is critical. The San Francisco community at large, and from individuals to public health officials to science, medical providers, San Francisco ASOs have led the way for over 40 years and have been on the forefront of the San Francisco model, and the San Francisco model lives on through COVID. We in this community have historical perspective and lessons to share with others, and they need to hear our experiences of hope for a brighter future. Today we gather as storytellers to share lessons with each other and to pull the thread from one experience of one pandemic to another. It is about stories, and we've got some great storytellers with some great history. So what I would like to now do is each of the panelists will have a short opportunity to introduce themselves and to speak to where they've been and where they are today. And I'd like to start off with Dr. Bennett, please. Is Dr. Bennett not with us yet?
I don't believe Dr. Bennett is with us just yet.
Okay, then we'll hold off on Dr. Bennett. We'll go to Diane Havler, Dr. Diane Havler.
Oh, thanks. Hello, everyone. It's really great to be here, and thanks for joining us. Briefly, I am an infectious disease physician, a scientist, a professor at, and run the HIV and infectious by myself. My story began with HIV when I read this report in the MMWR and legal school. I got in my small blue Honda Civic and I drove across the country, and I'm a doctor during that part of the HIV epidemic. Over the last my career and my team to improving HIV with different treatment to prevent new cases, and citywide, nationally, and globally of trying to and win over the HIV epidemic and size as this event is today, always in the community. And when SARS-CoV-2, reading about new outbreaks, when I was reading about the crew to sit on the sidelines and really mobilized our team who had a lot of years in HIV response to see what we could do.
Great. Thank you, Dr. Havler. I would now like to go on to and ask Ruth Clements to introduce herself. Thank you, Ruth.
Good morning, everyone. My name is Ruth Clements. I work for Quest Diagnostics. I head up the infectious disease and immunology franchise. And if you had asked me, last year, if I would be in the midst of a pandemic, working like crazy to get the right testing, to the market to help combat this, I would not have believed you. And it's been, a long journey. Many people in Quest have rallied since January already. I think the world first learned about the virus late December, and we started immediately discussing internally, what can we do? How can we help? What do we need to do to prepare for this virus coming to the U.S.? And it's been an heroic effort on our side to get testing to the market, but at the same time, we are also seeing the disproportionate impact that this pandemic has had on underserved communities, which has, not gone unnoticed, and is something that we really want to tackle. So I'm proud to be part of Quest. I am very honored to be part of this panel, and I look forward to our discussion this morning. Thank you.
Thank you, Ruth. I'd now like to ask Brett Andrews to introduce himself. Brett.
Good morning, John. It's good to see you. I'm really thrilled to be a part of this discussion as well. First, a big shout out to Quest Diagnostics for inviting PRC to co-host this community think tank, this healthcare community think tank. I think we cannot have too much discussion around this particular issue. It is important for us, those of us who are in this field and in this work. It is our high responsibility to get accurate information to our communities, particularly communities of color and disenfranchised communities. So I'm really thrilled to be a part of this discussion. I am Brett Andrews. I'm the CEO of PRC. I had the honor of serving in that role for the soon to be 18 years. So it's amazing how time goes by. And so many of the folks who are on this call and panelists I've worked with and are friends with. And I just think about the community of friends and colleagues that have come together to address one epidemic, HIV, and now coming together and bringing their knowledge, their skill, their understanding, lessons learned to COVID. And I think that there are ways in which we can highlight and elevate the work that we do in San Francisco and see it again as an example and a model of integrated care. And my hope and goal is that for those who are joining this particular call, walk away with some strategies, some answers to some questions that they may have. And certainly I know that we're gonna make ourselves available afterward for some questions as well. So I'm thrilled to be a part of this discussion, and it's
Great. Thank you, Brett. I'd now like to ask Billy Lemon to introduce himself. Billy.
Good morning, John. Good morning, smiling Brett. My name is Billy Lemon. I am the executive director of the Castro Country Club. We are a small nonprofit in the Castro district that helps folks find recovery from a whole range of substances. We've been here for 37 years. And I am in my 6th year in this position. John is a former board member. He is also a mentor, and Brett is also a mentor. And so I feel like this is a very nice moment. That being said, I think Brett introduced the topic that I am going to focus on, since I'm knee deep in the trenches with folks every day. And I think what what is going to be very relevant is the idea of getting accurate information to the community. I recognize that just being on this call, I have a level of opportunity and privilege that is not accessible to many of the folks I try and help every day. And so I feel like it's my responsibility to reach out to businesses in the community, much like Quest is doing today, and providing this and find a way to be able to lift all boats in the community and help folks in a way that is significant and gets them the information that they need. I'll talk a little bit later in the longer portion, the relevant connection between HIV, long-term survivors, the Castro Country Club, health outcomes because of recovery and because of substance use disorder, and the relevant information that I'm hearing now on the ground about how folks are struggling to cope. So I am very happy to be here. Thank you very much, John.
Thank you, Billy, and thank you all. I think for those attendees, I think you can see the makeup of this panel is indeed profound. From those that are right on the ground, providing the services such as PRC, those that are providing and doing the research on the medical side, such as Dr. Havler, UCSF, as well as SF General, to Quest Diagnostics that is on the leading edge of diagnostic health, improving health outcomes through diagnostic services and cutting edge that, especially with COVID right now. And then of course, the Castro Country Club and the work that they do on a day-to-day basis with those that are most at risk. The first question was originally going to Dr. Bennett, but I'm going to open it up to all, but ask Dr. Havler to perhaps speak to it first. The CDC and other studies, as we've already spoken here a few minutes ago, has identified that the Latinx community, as well as the African-American communities, are disproportionately impacted by COVID. What are the key factors that you see contributing to this impact? And do you see a marked difference in these factors as they continue to play out in COVID?
Thanks for that question. I think that it is so clear based on the data that communities of color are really disproportionately affected with this epidemic, and nationally, statewide, and locally here in San Francisco. So what are the reasons? So one of them is just day-to-day risk and exposure for the virus. Certainly at the beginning of this epidemic, when things felt very chaotic and there was not appropriate protection measures in place, anyone who was a frontline worker was at increased risk of being exposed and getting this particular disease. Individuals who can maintain their job and income by working at their computers at home. Fortunately, many companies realized who wanted to protect their employees that they could do that and say, no, it might be tough, but this is what we need to do. Not being able to work at home, and this is what we found out in the first mission study, is probably one of the most important risks. Third risk factor is that some of the living conditions and in terms of number of persons that are living per room. As we were working with the community, people are just trying to make ends meet. And when one is trying to live in a city that's as expensive as San Francisco, people share housing, they share rooms. And we found that the average number of persons living in a household, which could be one room, was approximately 5 of those individuals who were infected. And then just think about food. Some people can just go on their computers and have it delivered to their house. But if one is not in that socioeconomic class, then you have to go out every single day and get food. Finally, I would say one more is that we know some of the risk factors, which are co-medical conditions, diabetes, hypertension, heart disease, other heart disease, can be more common in communities of color, not because anything they do, because of their lack of access to healthcare, which is purely a reflection of the disparities of our society and access to healthcare. So I know I'm missing maybe some of the key ones, but I just wanted to share, those are some of the reasons why we're seeing these individuals disproportionately affected.
Thank you, Dr. Habler. Ruth, could you also just touch on that? I know you spoke to it briefly in your opening remarks as the impact as through your diagnostic service.
Yeah, I would love to add to that. I mean, one of the things that I see in particular in the African American communities, also the lack of trust of care, just not trusting the healthcare system, not having the right access to care, and the fact that there is historical and systemic racism that unfortunately African American and Latinx populations are still experiencing. And coming back to what Brett mentioned before, and what Billy mentioned, the education, the knowledge, there was, especially in the beginning of COVID, this belief that, COVID is not going to impact African Americans, which is, completely false. But people were believing that. People are not taking it serious because they don't have the right education. They don't understand, some of the underlying conditions that they have because they don't know their health status, and therefore not realizing the impact that a COVID-19 infection can have on them. So I think it's that not trusting the care that they're getting, not having the right access to care are part of the root cause of why we're seeing some of this disproportionate impact.
Great, thank you. The next question goes back to Dr. Habler. As a leading HIV expert, what similarities do you see between the AIDS pandemic of the 80s and our current day battle against COVID?
Yeah, I think you made some really just incredible parallels with your opening remarks and your op-ed. I think any infectious disease, what do we see at the beginning? We see fear, we see stigma, we see misinformation, we see lack of information. This is happened for any infectious disease. Now with social media and all, it's good and bad, because good information can be spread quickly, and conspiracy theories have just been, I would say, with this particular, I think so the HIV epidemic, another parallel is, this is just human nature, and the only way it becomes more real is when your partner, your family, someone get really sick, all of a sudden it starts getting more real. If we want to link it to, testing as there's education barriers. We, for a long time, in the most affected areas of not have low barrier testing. And this just for people going to testing. And also this happened, we all know at the beginning, there's nothing to do. There's no treatment. And this is the thing for COVID, is COVID test. Okay, we, for sick people, have treatments that are improving, but we don't have right away that will reduce the transmissibility to your loved ones. We don't have anything, and what to do is to isolation and quarantine. And the question you asked me, we asked just in our last survey we did at Bart Plaza at 24th and Mission, how many people with their regular work, financial support, if they stayed at home, and only 22% did. If you have to work, you're going to go out and work. So there's a lot of news we have right now. I would say in HIV, we have when people are sick. In COVID, what do we have in that response arm? So I think those are, some of the parallels, differences. Certainly the viruses are different just in terms of HIV as a lifelong virus. Coronavirus, although there can be long-term effects, which we'll maybe talk about later, it's much more of a shorter-term virus. COVID, as we've all seen, is just incredible. I mean, I don't even been into it. I think all of we're in some kind of time warp. I mean, it hasn't even been, numbers are just astounding. I think also, I just want to comment on something is, so you alluded to, John, that we need to make happen. The only way to respond to the epidemic is when we have partnerships, science, policy makers, the community, and we have safe places to talk. And we not only talk, we've learned is about listening. We don't all have to agree, but that is something that we have learned from the HIV epidemic. Not easy to do. And also, I would agree with you as similarities. We are a model to our state and to the country of how to respond to COVID, and we have a ways to go.
Great, thank you. One last one before I move on. I just wanted to, if you look to the horizon over the next, we've only been in this battle for 6+ months, which seems like 6+ years with COVID. As you look to the horizon over the next 6 months, what are your key watch points or concerns that you see that could be emerging that we need to be prepared for, both from community response, service organizations such as PRC or the Country Club, as well as testing organizations and diagnostic services like Quest?
Okay, thanks. I think one thing which a word that we struggle with still with the HIV epidemic is complacency. So we now know our numbers are going a little bit down. Everyone's like, great, oh, we can go back to normal. False, okay? Just completely false. And it's always been so difficult for us in the AIDS epidemic when there's 37 million people living with the disease. It's like, why isn't it? So I think with COVID, as I said, it's just fast motion. So what we need is no complacency. Like San Francisco, we opened up a little bit, Memorial Day came and we saw a surge. So as we're opening up this time, we have to be about our public health measures, really, which are mask wearing, supporting the most affected communities, which that means education, financial support, and also all the shameful things that happen in our health system, proving things to reduce these disparities, because this, again, opportunity to do that.
Great, thank you. Yeah, you're exactly right. It's how we as individuals take personal responsibility and are the example that others see. I mean, back with the AIDS crisis, it was about taking responsibility with a partner, perhaps. Now it is a responsibility of taking responsibility for the entire community you live in because of the transmissibility. Thank you. Ruth, this question goes to you. What type of statistics do you see around preventative testing among some of the key populations? Dr. Havler has already mentioned some of them, but what do you see as the key drivers there that are on the horizon for us to look at? Obviously, as many of the attendees know, Quest is on the forefront, leading the charge regarding COVID testing across the country. And what has it told you so far?
Yeah, so well, first, to set the stage, we know that an estimated 70% of the healthcare decisions are based on lab results, and that understanding your health risk and your health status plays a big role in getting people the right care and helping them to get and to stay healthy. And as we briefly touched upon already, there are deep-rooted barriers to accessing healthcare for marginalized populations, and we certainly see that play out in the testing space. You know, mistrust, I mentioned it earlier, lack of healthcare access and education, compounded with a fear of knowing or concern that even if you do know your health status, that they may not be able to effectively get the healthcare that they need. That results in a trend of unfulfilled or delayed lab testing or non-compliance with routine testing recommendations. So as an example, you know, in particular in the FQHC space, which we know provides the lion's share of care to underserved communities, colorectal and cervical cancer screening rates are below recommended national screening targets, and medically underserved populations are more likely to be diagnosed at a later cancer stage, leading to worse outcomes. So while I want to, you know, commend the tremendous work that has gone into the effectiveness of getting to zero HIV infections in San Francisco, and it's a model that we could definitely learn from and apply to COVID. This panel is all too familiar with the national statistics around HIV, where it's estimated that 1 in 7 people who are infected with HIV don't know that they are infected and are thus unable to benefit from treatment and may be transmitting to others. So not knowing your health status has a ripple effect, particularly when something like COVID enters the picture. Patrick touched briefly on the CDC reports that existing conditions like asthma and hypertension or obesity or chronic kidney disease are all more likely to lead to hospitalization during a COVID infection. And not only are these conditions significantly more prevalent in communities of color and low-income neighborhoods, the likelihood that these have gone undiagnosed or untreated is much higher. And as a result, patients may not even know about their underlying conditions that could impact the severity of a COVID-19 infection. So it comes down to an issue of lack of education for various patient populations around that downstream impact that not knowing your health status can have on your ability to stay healthy in the future. Though we are encouraged that it seems like as a result of the heavy focus on testing in the country, as a key component of combating COVID-19, that people are beginning to understand the value of testing like they didn't before, which we hope will improve health outcomes across the population.
Thank you. That's great. To summarize briefly, if I hear you correct, what you're saying is that with COVID in our communities now, both there's fear within communities of color because they don't have trust at times within the healthcare system, as well as within the HIV and AIDS populations. The concern can be either individuals are not having their preventative testing and their follow-ups with their medical providers, and therefore they're at risk because they don't know how they're doing. And then secondly, beyond that, because of the fear of going into healthcare environments at the present time, individuals may not be getting tested. And so we will have potentially increase in infection rates because the population does not know, some of the population does not know their infection status. Is that correct?
Yes, that's correct. Yeah.
Great. All right. Thank you so much. Brett, the softball is going to come your way. You work in the community on a daily basis, and you have, as you said, for nearly 18 years with PRC, and helping to address the social factors that drive access to better health, economic opportunity, and social dignity. What kind of secondary effects are you seeing across the community with regards to the rise in unemployment, loss of housing, mental health related issues, along with other important resources to help people get access to the needed social, medical, and social health related services?
Yeah, thanks for the question, John. It's a big question, so that wasn't a softball.
but I know that you can hit the ball.
That's your softball. I don't want to see your hard ball. Here's what, I will say this. And I always say to many of the staff and to the board, PRC is only as successful as the backdrop in which it works. And that is, what is the state of San Francisco? What are the ways in which the city overall has made a decision to respond to COVID, to respond to homelessness, unemployment, HIV? And what I'm proud to say, even though there is so much more work to do, is that San Francisco is a model in the fact that on a consistent basis across administrations, they have made a significant investment in public health and in its community partners. I have worked with many mayors and certainly many board members on the Board of Supervisors, and what was consistent and clear and a through line of a value is the understanding and the importance of partnership. So San Francisco has done an extraordinary job of public health partnering with its community-based organizations, PRC certainly benefiting from that, and the community ultimately being the ultimate beneficiary of those. In what ways is that important? Well, I will say that in many ways, and Diane understands this, as we sought to address getting to zero in HIV, it was not going to happen unless there was a partnership between the community and San Francisco. And that is significantly important in communities of color, because we want to provide culturally appropriate services. And in some ways, the government can't do it all. And that is where nonprofits step in, particularly in the Latinx community, African-American community, API community, where we would go into those communities and make sure that there were folks who looked like, acted like, talked like, engaged with, had life experience of the individuals who were seeking to access services. Most recently, PRC, among many other African-American led and or serving organizations, and I saw Diane there on that Saturday, went into District 10, which is a heavily African-American populated area here in the city, to provide COVID testing. And the same exists for the Mission District, because we understood the value of going to the people and meeting them where they are, and not expecting that just because we would build something that they would come to us. So I want to say what an incredible value it is to have partnership. That same partnership we have even with the for-profit community as we think about congregate living and behavioral health services and homelessness services. What were we to do with the navigation centers that we had worked so hard to build and to develop and create capacity in? And now we had to figure out a way to keep our homeless population healthy through COVID. And we went to the hotel industry, and many of them stepped forward and were able to provide rooms for our homeless population. And while that strategy continues to be developed and debated, the fact of the matter is that we were able to do what we needed to do in order to keep the most vulnerable populations safe. At PRC, we provide a broad range of behavioral health, mental health, substance use, residential programs, and wraparound services. And I'll talk a little bit more about those later. But the last thing I wanted to say is the value and the importance of keeping our frontline workers healthy. PPE was everything. PRC invested a significant amount of resources into masks and gloves and sanitation wipes and hand sanitizer, because we knew that our services needed to continue. These are essential services that need to continue to be provided during a difficult time. We knew that our staff, our valued staff, were putting themselves at risk by continuing to provide that service. So what could we do? And many other service providers certainly took that same stance and did all that we could to provide PPE to them. The other thing that I want to just highlight, and I'm proud to say that PRC was able to do this, we provided, often you've heard it called hazard pay. We did hero pay. We wanted to provide a premium to our staff, our frontline staff, to let them know we thank you and we value you for staying on the front line and standing in harm's way as we now address HIV, mental health, substance use, homelessness, and now COVID. That is a lot to put on any one individual. And that is what we recognize, and that is what we implemented going forward. And that was our taxpayer dollars going to good use through PPP. As we got a significant loan from the federal government, those are where those dollars were directed. And I'm just thrilled that we have been able to, in the many clients that we see, and we house about 310 clients every night throughout the last 6 months, we've only had 3 cases of COVID, 3 cases. And that's congregate living across San Francisco, across 12 different treatment sites, and 20 different supportive housing sites. So it's clear the work that we are doing is paying off and is paying in good dividends. Oh, John,
well, you hit the ball out of the park, so there was the softball. So just to recap, so if I hear what you're saying, Brett, some of the key factors is to tear down the walls of distrust and fear that many in the community have, and build more relationships of trust that are culturally competent, that look like those we're trying to serve, those higher risk populations in the community. And to work collaboratively, as San Francisco has for 40 years in the AIDS crisis, with public-private partnership and nonprofit communities coming together to leverage those resources, and the government the solutions happen on the ground, from the ground up. And certainly PRC has been at the forefront of that over the years, as well as obviously SF General, UCSF, and with support of organizations like Quest as well. Thank you. Billy. So I'd like to hear a little bit about your story and how you have come to us through the process today. You are connected to so many of these different organizations, both personally and professionally. And as you do, I would love to also hear the work that's going on in the population that the Castro Country Club serves, and specifically how COVID has impacted not only the club itself, but by the club being impacted, how that is impacting the community, and what sorts of efforts and strategies you've put in place to sort of continue to keep those services for those most at risk.
Okay. Good morning, everyone. I never really am super excited to follow John or Brett. It feels super, I feel like I'm like standing amongst giants, but I'm going to do my best because I'm, it says they wanted me to tell my story, and there's always this weird thing. I am the lived experience ED. I have a history of substance use, a long history of substance use. And I found recovery. And now I get to share my story with the community and run a small nonprofit and get to be on the ground with folks. So here's my story. I moved to San Francisco 20 years ago. I went to San Francisco State. I was a German linguistics and history major. I am not quite sure what I was planning on doing with it, but at the time it sounded fantastic. It did not work out that well. I'm 49 currently, and San Francisco in the late 90s, early 2000s was a booming place for young gay men. I was sidetracked, and that sidetrack led me down a path of addiction that lasted a good decade. And then I found recovery, and I found the Castor Country Club. What I will say is I think Ruth touched on this. I think Dr. Havler touched on this. John definitely touches on it. Brett is a partner in a program that we have that we definitely touch on it. And life experience is important. It helps people heal, and it helps people trust. And the things that I think that Sam and I talked about earlier when we were prepping for this, and I think the things that are most important for Quest to hear around this are that the key challenges, I think, for us as San Franciscans and as leaders and as businesses is to create a method by which folks can get accurate information in a method that is broken down and easily understood. I think that fear is rather paralyzing for folks, and is promulgated by inaccurate information, which I feel like we have had a lot of since the beginning of the pandemic. And what the pandemic has felt like for me as an ED for a small organization that helps people get sober, and whatever that looks like for you, it may mean less use, it may mean abstinence, it may mean support. All of recovery is built around community. So when the epidemic hit and I had to shut our doors for our brick and mortar drop-in center, the idea, it's arguable that the most important part of the recovery model is community of some sort, right? We see that at PRC, we see that at the Grove, we see that everywhere. Community is very important for people to heal. When you take that out of people's daily lives, it was a struggle. That combined with fear, I think was very similar to what folks felt like in the early parts of the epidemic. The country club has been in the Castro in the same spot for 37 years. There have been various iterations of the country club, but at its inception 37 years ago, it was basically a place for folks to go and meet who were dying, right? That's what it was. That's how it started. It has developed over time to serve many communities, but we are inextricably tied to HIV, 100%. And many of the folks that now serve on my board or have been long-term volunteers are folks that originally thought they were probably going to die and have outlived what they thought their life was going to be. So here's where the intersection of the pandemic, the first one, and COVID meet for the Castor Country Club. What I'm noticing is that the same disinformation or access to accurate information for folks in the early part of the HIV epidemic is the same way some of my clients are feeling now around COVID. They have inaccurate information and they don't have access to a continuum of care that is actually going to help them. So for instance, I have the opportunity to run a Zoom support group 3 days a week, right? We started that right when shelter in place started. If I can't get my clients connected to Zoom to be in support group, then I can't help them navigate the difficulties of their daily lives and what they're going through. And there are several factors there. There is access to Wi-Fi. There is access to a device that actually connects to that I can actually connect to my doctor or my clinic. I have fantastic insurance and I have Wi-Fi here, so I can certainly access my doctor really, really easily. I have noticed in the past 5 months that has been a very big impediment for community, just getting access. I think that folks are also really, really scared. What I learned, I did a little, I peppered group this week and I asked them, what are you most scared of? And what they said was, I'm most scared to go to the hospital and get COVID. That's a real fear. Just like it was a real fear in 1984 during the height of the epidemic. So I think the answer for Quest business leaders, us as community leaders, is we need to figure out a way to lift all boats. I know here at the Country Club, we've created an angel fund over the course of the last 3 months, and we're trying to get people connected in the best way we know how. I've been walking people through Zoom, getting on Zoom lately, just so they feel connected to something. And that's really, I think that's where we're at right now. I promised Sam that I would run under 8, so there we go. I am at 7:47. Boom, we're gonna right there.
Thank you, Billy. To speak to that briefly, I way back in the early days, for a period of time I was on the PRC board. I was a client both of the benefits counseling side as well as the employment services side. Then became an employee of PRC's. I think that what I hear Billy saying, and I was on the board, and Castor Country Club helped save my life. The reality of it is giving individuals self-esteem, giving individuals the will to want to make healthy decisions. And those healthy decisions are then driven by diagnostic services, so they can make decisions based on science and reality. But if individuals don't have hope, just the same to some degree as if they didn't have hope back in the days with the darkest days of the AIDS crisis, then they wouldn't wear a condom. Today, that is playing out, they won't wear a mask. So I think that the parallels here are profound, and it is a matter of isolation affects mental health. I mean, I can tell you, I love going to in-person recovery meetings. The Zoom recovery meetings, not so much. But I also then know it doesn't help my mental health not to be connected to community. So I think it's community, it's individuals supporting each other's that bring healthy outcomes. Thank you very much, Billy.
One last thing, it's about access. If they can't
Sure.
access services, they're never going to feel connected to community. And I think that's the one point I want to drive home today.
Well, I think you're right. I mean, and the key, as I recall, is that when the club was shut down and it did not have access, that was such a struggle for the organization and for the clients that serves. And since that time, you've been so creative in being able to help access through technology and then slowly open up the club in a way that was safe for people, because they also need to be, continue to be protected, but grow and build back in community. Thank you. as we move on, Brett, I wanted to ask you, could you give us an overview of this, the services, the evolution of PRC, the services that you have today, and how those are connected, your clients and providers with each other today?
Sure, John. I just want to say a word about Billy, and I'm thrilled of his community leadership. I think for all of us on this call and for those listening, cannot underscore or overestimate the value of hearing someone talk honestly and candidly about their story, because his life shared experience that we all have is so meaningful to others. The connection that is being made between the Castro Country Club and PRC, particularly our Lift Up program, where people, I often call it bearing witness to each other's lives, talk about their own journey and normalize the journey that they are on, from challenge to triumph, I often call it. I go to have been to 2 of the graduations, and it's just been remarkable. So I just wanted to say a word of acknowledgement for Billy's leadership and the programming that is coming out of the Castro Country Club. What a value it is to our community. PRC, John, is, as you know, and you're right, there's so many connections on this call. I love it. John was the development director for many years, and John and I were doing our absolute best to raise as much money as we could for PRC. So thank you for your work with PRC. PRC started like many AIDS service organizations. It was in response to the AIDS crisis. In 1987, there were just a small band of attorneys who were seeking to help folks get disability benefits who were being denied their claims at Social Security. And that small band of volunteer attorneys came together and formed what was then called AIDS Benefits Counselors. And it remains such an important and valued service. I'll talk a little bit more about that later. That the organization was in that state until the mid-90s, and then there was another small program. I often say this particular program, what was called Employment Services, was an idea whose time had not yet come. We unfortunately were having more people dying of HIV and AIDS than were living. But for those who had hope and had a view and a thought that they were going to live, another group of volunteers came together to create an employment services program. And in the mid-90s, which now we know with the introduction of HART, you know, many years are handed back to an individual. And the question then becomes, what are you going to do with the next 10 years that have been gifted you, or the next 20 years? And so many of us find our value through the work that we do on a daily basis. Why would we not think that others would be asking themselves that same question after experiencing a life-defining health event? And so our employment services program and AIDS benefits counselors came together to fully merge to become Positive Resource Center in the mid-90s, and we functioned under one roof from the mid-90s until 2003. That's when yours truly came on board. And what we've understood was the work that we were providing for the HIV community could be easily transferred to the mental health community, helping people go back to work, helping people gain disability benefits. And we expanded our services in 2003 to serve the mental health population. Diane knows this very well. Not only did that open up our services to a broad community, we had so many folks who were struggling with mental health and substance use issues, but it also opened us for new funding as well. So we were able to expand our services. And from 2003 until just about 2015, we had natural growth that grew that agency from about $1 million to about $6 million. Most recently, just about 3.5 years ago, 2 organizations that were in the middle of an executive director transition did come to PRC, and we discussed bringing these 3 organizations together. What was key and a priority for all of us was, if it wasn't a benefit to the community, if it wasn't of a value to the client, there was no reason to bring these organizations together. And often we can see strategic partnerships driven by ego and other issues, and that was what we didn't want to do. So we went to the community, we asked what folks thought about it. We looked at our client database and saw that almost 30% of our clients had used one of the three organizations. The other organization is Baker Places, a behavioral health organization, and then a small organization called AIDS Emergency Fund that provides emergency financial assistance. 30% of the clients were shared between one or more of those, two or more of those organizations. So by April of 2017, three organizations, Positive Resource Center, Baker Places, and AIDS Emergency Fund, come together to form PRC. So what is PRC? PRC now is a multi-service organization. We're just about $30 million, about a little over 300 staff. Our significant core service is behavioral health. We have crisis care to residential treatment care, which is transitional housing while mental health and substance use services are being provided. And then we have long-term stability, which is our supportive housing. An example of crisis care is our Hummingbird program, a 2-week to 1 month behavioral health respite that we have at Zuckerberg General. We're opening up another on Valencia Street, which we're very excited about. Our treatment centers are throughout the city. We have 9 of those treatment centers. Those are 60 to 90-day mental health and substance use services that are provided 24 hours. Where the wrinkle comes in is we're under shelter in place. So wherever you were in any of our programs, you're still there because we're under shelter in place. So we are frozen in being able to move clients through the fullness of our programs. And we're looking to the city for guidance and certainly our public health officials to give us guidance on what we should be doing as COVID moves forward. But for right now, we have 300 people in place and taking care of themselves, safe and working on aspects of their recovery. And then our long-term supportive housing, we have about 144 beds across 20 sites where people live on a long-term basis, working on recovery and health and well-being. We're thrilled that we're able to provide that. That is housing. That is a form of housing. And if we can expand that capacity, we will. And there are efforts and community initiatives and citywide initiatives that are going to be doing that in the near future, and we're really thrilled about that. I just want to say a word about our wraparound services. We have emergency financial assistance, small checks that help people just get over an emergency crisis, co-pays. Right now, it's all about rent and keeping folks housed. So we're writing significant rent checks, cell phone bills to make sure that folks have their cell phone on and can communicate with their mental health provider or their primary care provider. Our legal advocacy program, 16 attorneys on staff, fierce attorneys, John knows this very well, who help people get disability benefits, SSI and SSDI. That they certainly are a crown jewel in the PRC crown. Workforce development in partnership, certainly with the Castro Country Club, helping folks at 3 stages, really some who've never been in the workplace, just talking about it, what it would mean to get into the workplace, those who just want to skill up and make themselves more marketable in the workforce market, and then those who are just ready to go and just want to do it in a safe, culturally appropriate environment, our workforce development programs. And then lastly, our peer-to-peer work and our housing case managers we have to make sure that our clients are engaged, remain in treatment and remain in care, remain connected, because that is a key part of it. Billy nailed it. If they are not connected, you really feel a sense of isolation, and depression is very high in our population. So that's just a short version of the myriad of services that we provide. And we see just over about 5,000 to 6,000 clients a year, about 5,500 certainly this past year. So not an insignificant effort in partnership with DPH and UCSF and the city and all of our many other service providers. So we're just thrilled to be a part of the solution.
Thank you, Brett. As our attendees, I'm sure can attest to and can experience, the work that's going on at PRC is truly life-changing, life-saving, improving the fabric of the community that we live in, one client at a time. And as he has addressed before, it's all focused on improving the individual's lives through culturally competent, focused wraparound services. So thank you for the work that you do. I'd like to ask Dr. Havler a question on COVID again, if I may. Many have heard that COVID-19 survivors drivers have at times been struggling and suffering with what I will call long haul syndrome, where their recovery is prolonged into quite an extensive period of time. And so it is not as though one gets COVID, recovers from the initial aspects of COVID. Many are suffering with long-term health impact. Could you speak to a little bit of what the long haulers or the long-term effects of COVID as you see it today?
Absolutely, I'd be happy to. John, if it's okay, can I just make comment
Yes,
on a couple of things that were
please.
said, and then I promise I
No,
will
no.
get back to
No, this
the
is a
long
conversation.
haulers.
It's a
Okay,
conversation.
well,
Please.
you know, I was remiss in not saying at the beginning, John, wanted to personally thank you. The Cisco is extraordinary to have you with all the wisdom that you share, and particularly how you put into words yourself. Thank you for that. Brett, I also, every time you talk, I learn something new and I gain no exception. And I want to just thank you. So easy for people to complain about all the things they see in the city and about people in need. And PRC does something about that, and how you've grown the program and how you put the clients at the center and how your emphasis on, you know, working together is just fantastic. Billy, I wish I would have met you before and we would have had more conversations. I loved what you said about the whole, you know, when you sat down, you asked folks, what are you feeling? And it's fear. This is just like such a simple concept. It's so easy when a crisis comes, people in positions with power and money just make decisions. They don't talk to people. They're like, what are the main problems? Same thing in our clinic. And one of the things that we have a new program called Pop-Up led by Liz Emberg, Monica Gande, Matt Hickey. And the idea is some people just cannot go to an appointment at 2 o'clock on Tuesday. They simply just need to show up when they can. And with shelter in place, and we were supposed to only doing phone appointments, we're like, there's no way we can ask these people, you know, to do phone. So we didn't. I don't know if it's civil disobedience are essential appointments. And it's just an example you're doing, you know, in the country club. It's about joking about the needs of your person, and all clients, and always, of course, putting safety first. And Ruth, I just see your name here, and I like, what a nice person to share a first name with. But it's not just the test, it's the person and how it's going to help their health. Okay, back to the question, John. So in general, this long haulers, first of all, bit of context. One of the things about COVID is not get critically medically ill, but if that doesn't mean that taking 2 weeks off of work has a huge economic and, you know, mental health shock. Okay, but critically medically ill, that's good. Secondly, fortunately, most people do not have these long-term consequences, but just like HIV, every day, HIV is an epidemic. We learn something new every day. We're only just at the beginning of COVID. So what I just want to say, some of the things I'll share with you next, they could change in a week or, you know, a month. So let me just say a couple of these things. Okay, so the people who are most likely to continue to have symptoms beyond their acuteness happen to be those who are older and who were, but like everything in medicine, it's not 100%. And this of all age categories. Okay, so what are some of the things that people get? Well, what are the organs that are affected? Multiple organs are affected, just like HIV. And one of the things that can happen is people can have longer standing effects of lungs. And people now have looked over time of people who complain of shortness of breath. Looks like there's some scarring more in the lower than the upper part of the lung. This is probably due to either immune response or a dysfunctional. That's what some people can feel, just chronic breath. Secondly, there's a study, the heart has receptors for the SARS-CoV-2 virus. Heart's a muscle actually. And what we know is that the muscle, and so your heart is a muscle, it pumps at time, and that percentage can go down during the acute phase and then that can be longer lasting over a period of months. The Brits just published a paper that was encouraging, I thought, which said most of the people that had seen that reduction of their heart by 6 months, or their normal where they started pre-COVID. During the acute phase, which sadly is long lasting, because who get COVID, it can affect the way your body clot, and you don't want to be clotting in the wrong place, like in your brain. So people can get strokes, which are long lasting, and they can get, also these clots can go in the tiny blood vessels. They also can cause some damage to your kidneys, which also, so if you ask me, what's the exact, no one knows that right now because we really don't have enough data. Somewhere probably, I would say, from what I've seen, percent, but if you're one of those 10%, you know, this is really, really important. All around the world who are longitudinally just time having people sign up. So, you know, volunteers, and we know how important it's been in the HIV epidemic to understand over time what these long-term effects, when do they go away, and most, is there anything you can do about it? So, as it is in HIV, you know, there's so many things that we had to do when people would have died if we wouldn't have given them at the time, had long-standing side effects. If we would have had other drugs, we would have used them, but we didn't. And as the intersection of aging happens with some of the things that we were done in early in the HIV epidemic, you know, we're seeing those play out. But I do think that people sharing their experience, those people who are comfortable participating in these projects where you do surveys, where you donate, you know, your blood and hair and all sorts of different specimens, so scientists can study them, not only could help the person affected, but also helps the broader community. I would have to say, it's been surprising. Like, you know, people always say to me, like, what are you most surprised about with this virus? I do think some of these longer term, long haulers, as we're saying right now, it's surprising to me, but okay, fine. It's okay to be surprised, but we need to do something about it. We need to utter, and even if it's only 5%, this is something we really quickly. And, you know, certainly a lot of this is going to be immune system, and many of the immunologists, the, you know, ones at UCSF have really to their, not stop doing HIV, but added to what they're doing, because you always learn something about comparing different viruses, SARS-CoV-2, the virus that causes COVID, into the projects that they are doing.
Great. Thank you, Dr. Hadler. I'm really pleased to introduce one of our panelists that had a conflict earlier, but she's been able to join us. I am so pleased to introduce Dr. Ayanna Bennett, who is the Incident Commander for San Francisco's COVID Command Center with San Francisco DPH. Dr. Bennett, welcome. I'm glad you were able to join us. I would love to just put before you a little bit of a question. First question, and I'll do it twofold, and you can answer both of them if you would. First, speak to the Command Center and the COVID work that you're doing there. And what you're experiencing on the ground in the city of San Francisco, and what you see are some of the key driving factors that those that are attending this today should be made aware of, and what we as a community and individuals can do to continue to keep ourselves safe and the community around us. So again, thank you for joining us.
I just want to jump in and say that's one of John's softball questions, as you can tell.
I'm hoping I'm getting the COVID grace that we all need when we're trying to do this work from our houses with our families and stuff happens. So that was my morning. Things happened. But I'm happy I finally made it, and I'm glad to be part of the discussion. So the COVID Command Center is basically the emergency operations center, which many cities and counties have set up to deal with the many overlapping and conflicting needs that COVID has brought up for communities. So the pandemic and illness and preventing illness colliding with economic disaster, colliding now with civil unrest, all kinds of things are happening at the same time. Heat, smoke. So clearly this is an emergency operation, and it continues to be. So we have renamed that the COVID Command Center only to help people understand that it wasn't an emergency operations center that was going to stand up and fold the way they usually do in a matter of days or weeks or even months. It's going to keep going on and on, probably at least for the next year. So I am the incident commander of the health part of that, but there is a part of that that's emergency management, setting up cooling centers, helping manage police and other interactions. And there's part of it that is human service agency, which is the part that is the designated shelter giver during emergencies. So the hotels where we have homeless residents, the sleeping villages, all of those things are set up by HSA. So the testing, monitoring the hospitals, setting up the field hospital, all of those things that are about preventing surge and trying to control this disease, those are the parts that I am involved with. For me, the message that I've gotten out of it that I think is the one worth sharing is that this is like everything else, at least in the aspects that are part of my work. So my other hat before this disaster, I'm the director of the Office of Health Equity at the Department of Public Health, which means I have a pretty good mental map of the way disease is distributed across the community, and it is never even. It has never been even. We concentrate negative things in some areas so that positive things can be concentrated in others. It is just how we have run our society for years. We have not fixed it. If you look at the way heart disease stretches across the city, it looks like our redlining map. COVID looks like our redlining map. And everything else that happens for the next decades that we don't fix it is going to look just like that. We could have said last year, if we have a pandemic, where will we need to do all of our operations, and pick the exact same neighborhoods where it turned out we need to be, because those are always the same neighborhoods, because that's where we have chosen to put the negative effects of our society. That's our choice. So that this is it, as it has been and will ever be kind of thing. I think we should all be aware of that. It shouldn't be a mystery, and it shouldn't be news. It should be the, oh yeah, it happened again, and we should be quicker about concentrating our resources there. And to the degree that everyone can understand that your chances of getting COVID are dependent on the number of people who have COVID in your community, which means I need to go where it is, not where it feels like I'm taking care of you to put it. So the fact that I have less testing in your neighborhood is actually for your benefit if you don't have high incidence in that neighborhood, because the person who's going to give it to you, probably that disease originates from somewhere else. So I'm going to go there. But that is not a politically easy message. We are more comfortable being egalitarian than we are about questions of actual equity. And in this case, efficacy. Like, it's just not going to work well for me to spend a lot of resource on people who are in an office who actually don't have that higher risk, but have a lot of anxiety. But it's very hard to make that work in the midst of people's sense of personal threat, right? We all get a little bit self-involved when we consider ourselves under personal threat. And the chances that you are under actual personal threat are actually probably much less, right? Because the COVID is not evenly distributed either. If there's more over here, it means there actually is less over where you are. But people are not necessarily appreciating that fact, and it's hard to hear in the news. We hear about the number of deaths, not the fact that many of them come from really concentrated areas, and that much grand swaths of the country are actually doing relatively fine, and others are being completely decimated. So being able to understand that unevenness and be comfortable with it, and being able to message it effectively so that people will allow our efforts to be uneven, I think is actually the work of probably a couple of decades, getting people used to this kind of response, and we are not there yet.
Right.
Can I just throw out something really quickly just to talk about our what we talk, this network of folks, which we always say there's like 1 degree of separation, just so that everybody knows. Ayanna, I'm going to call it out. We were starting to address this in a significant way a year ago. PRC started the Black African American Leadership Council, of which, and I'm not dumb, Ayanna was a co-chair, along with myself and Kelly Dearman and Tamika Moss, to address specifically this. In reading the Black African American health report, and we saw that basically in every matrix we were almost dead last in almost every single one of them. We knew that that report was a call to action for us to come together, and about 40 of us have continued to meet over the year. Ayanna had to step off as a co-chair, but still remains a part of the group to address these health and economic disparities that are across San Francisco. And I always say, if we can't address it in San Francisco, it'll virtually hard to address, because we're a city that's, you know, my grandmother would say is halfway to Rice. You have boiling water, you have people who care, you have resources at your fingertips. So we're looking to once and for all tackle this and figure out what we can do that is needle moving in our community, particularly in people of color communities. So thank you, Ayanna, for being a part of this.
Brett, I actually think we're sometimes hampered by having boiling water because people feel we're already right.
Right.
They think we're already probably pretty good. And so the idea that it's horrible somewhere within the city limits is a message that's hard for them to absorb.
Well, I think you're exactly right. Thank you, Ayanna and Brad as well. You know, it's about viral load, right? And we experienced that with the AIDS crisis, and it's my own personal viral load that I live with. But my personal viral load is connected to the community's viral load. And when you start dissecting the community into smaller pockets, you can start identifying where you need to take strategic interventions to continue to reduce that viral load, whether that be in the trans community and the communities of color and the like. And so that is where I see you sharing. It is about testing. And that's connected back to Dr. Havler, and that is connected to Quest, because we need to know what we don't know. We've got to discover where the virus is and where it's moving. And that is only going to happen through strategic ongoing testing. And of course, there's so much misinformation out there. So thank you for sharing that. And I know Billy wants to pipe in over here as well. Billy.
Thank you, Dr. Bennett. I was trying to hold it together because I wanted to jump up and scream when Dr. Bennett started, because it's exactly what I was wanting to hear, right? That we have to have the part about having tough conversations about opportunity and equity is absolutely essential. And this is a moment. The COVID has provided us another moment to have this conversation, to have this very difficult conversation. And I've been having it with board members, and I've been having it with community members. But thank you, Dr. Bennett, for putting it in words that I couldn't get to myself. But what you said was absolutely profound and perfect. So I just wanted to.
I just want to give us a break that we're not already good. I want to give, because this situation has been a real. It has been in sometimes so high pressure and so chaotic with so little information in the beginning, when there was a point where we had a few thousand swabs for the entire department. So it's just been an incredibly difficult situation. And we all know that when people are under pressure, their biases get elevated. Even their biases about community, their biases about how much their own interest should play into things. And so I think we did a lot of things by instinct, by rote, by bias, by all of those things that you do when you're scrambling that may not have been what we would do if we had been able to not be juggling 50 things without enough hands. But we're at a different point now. And so even if people were having a hard time hearing it before, now's the time that I think those conversations should really start to hit better, I hope, as people calm down a little bit.
Exactly. Thank you. I want to move to Ruth, if I may. Quest is a global leader in diagnostic testing and services, helping to improve health outcomes and community health in general around the globe. But specifically, the work that Quest has been doing over the last 6 months as it relates to COVID is indeed profound. Could you speak to where you see things standing today, the progress that has been made over the last 6 months, and where you see going in the future? And then second to that, there are obviously new and emerging testing opportunities out there, different kinds of tests. And I think, again, we're not getting enough information from the public sector as to what test is the right test. What should we consider? Could you speak to those in the brief time we've got left?
Yes, I can. So there are two ways that we are driving towards better access to testing, medical and operational innovation, as well as a newly launched initiative in partnership with our Quest Foundation aimed at reducing health disparities in underserved communities. So let me start with the medical innovation first. So we have been and we are continue to rapidly ramp up testing capacity across our network. I think everybody has heard in the news, you know, the issues with turnaround times and supplies and whatnot. And we have recently introduced pooling as an effective way to drive that expansion. And our current forecast is that by the end of this month, we have the capacity to run 220,000 diagnostic tests a day, which will allow us to meet the demand that is out there. And at the same time, we're also expecting a second wave, right, with the flu season upon us. We are awaiting EUA approval or approval by the FDA for several new tests, both on the surveillance side and screening side. And also, we are planning to launch some combination tests that test for COVID and flu at the same time, because as we enter flu season, it will help providers and patients to address and treat symptoms that may be similar, but require a different treatment regimen. In terms of the types of tests, we've heard it in the news, right? On the one hand, you hear people saying, well, the diagnostic tests that the labs are running are too sensitive, and we just need a point of care test that can give us all of the answers. I think, you know, as Quest, we continue to look for new ways of testing, for new tests that can serve that need that is out there in the market. We do believe that rapid tests, point of care tests like an antigen test, for instance, can play a big role in surveillance of populations or screening of students or employer populations, you name it. So I think all of these tests in concert with each other can help combat, COVID-19 and allow for us to not just screen and do surveillance of the asymptomatic population, but also make sure that we have the right and accurate tests for those who have symptoms and are looking for a diagnosis. To touch upon that second part that I mentioned, we launched a new initiative recently, and Brett knows about it because I did consult with him on that many weeks ago. It is a commitment to provide free testing and improved testing access, because I think oftentimes access and not having the right information is a big part. So we're really looking to help close the healthcare gap for communities who have been disproportionately impacted by COVID-19, and in the hopes of building long-term solutions to address social determinants of health, and by driving that awareness and education around the importance of knowing your health status amid this pandemic, but also beyond, right? We're as an organization, and we're not just jumping in because of COVID. We want to be in it for the long haul, because these disparities have been here. This is nothing new, to Dr. Bennett's point. So right now we are in the process of listening to and learning from and looking to partner with local organizations that can really help our collective effort and impact go further. And I'm very proud that the organization has allocated more than $100 million to this effort, which I think is quite significant. And we're really looking forward to making an impact and do what is do good in essence. Thank you.
Thank you. So we've got about 5 minutes left, and I'm going to ask everybody who wants to stay on. We've got some great questions that are in the queue. So I'm going to ask if anybody needs to drop off as an attendee, please feel free to do so at the half the hour. But we're going to probably go about 5 minutes, maybe 10 longer, so that we can take some of the questions that have been posed. The first question, and I'll open it up to probably either one of the doctors or perhaps to Ruth. We know that the data nationally shows that obviously age impacts the death relative to the potential for comorbidities. Could you speak specifically to San Francisco and what we're experiencing in San Francisco with regards to death rates associated with COVID and age?
So our pattern is not remarkably different from other places in that it is much harder on older people. Where I think we have an advantage is that we have kept a very low fatality rate in our nursing homes. And if you look at where the gap is between us and other people, that is it. It is nursing home deaths for the most part. We have certainly not had none. I wish I could say that, but quite a bit fewer than other places. So there is always that correlation that it is harder hitting in older, especially frail older populations, but there is no disease that follows the book exactly. They just don't. So something that is meant to attack older people will attack middle-aged people and some young people, and people come in a variety. And so whatever the receptors and other conditions that this virus needs in order to be able to replicate and cause the inflammation and vascular problems that it causes are inevitably going to be present in other people. And they have been shown to be present in some children, in some teenagers, in some 20 or 30 or 40 or 50-year-olds. So there will always be those. And the cases are clustered around people who have more exposure. So they're clustered around middle year workers, so 20, 30, 40s. And they're becoming more clustered around younger people and children. And it's likely that that epicenter of workforce exchange has become family exchange, which is both older people and younger people, right? As people's children and grandparents are home. And so we're seeing those areas rise up in that graph. But it is harder on older people, but is not by any means exclusive to them, particularly in San Francisco. It is, the weight of it is being carried heavily by people who are younger.
Great, thank you.
Thanks. Maybe Anna could just add a little bit to that is, it's not, this reminds me of HIV also. It's just not about death. It's about serious illness and suffering. And, being in the intensive care unit for 3 weeks is not a piece of cake. And in San Francisco General, a lot of people are in the intensive care unit in their 40s and 50s, and they're Latinx. And that is exactly what Ayana just said, is these are the people who are really being affected. And it's just heart-wrenching when, somebody's in the intensive care unit, 3 of their kids are, they want to come visit. And then all of a sudden, 2 weeks later, the wife is in. So we have to be mindful of, as we think about the harm that this virus is doing, absolutely it's death, but it's also hospitalization care unit, the medical, including effect on people who are struggling with substance use, including on financial and food insecurity with.
Great, thank you. Billy, I've got a question for you. What do you see as the most important things to consider when educating and providing information and support to marginalized communities, and how can we assist them in increasing access to care and staying healthy? You're muted.
So this is that weird circular question where if I don't have access, if I have a flip phone that I am relying on as my main source of communication with the world during COVID, then I am not able to access information in a way that is helpful to me and my family. That's number one. So access to digital is important and life-saving in this scenario. Number two, information, I think, or what I've noticed during COVID, has to come from a trusted source. So in my Zoom support groups that I've been running, I've actually been going to the DPH site and breaking down Dr. Colfax's bulletins for my community members, right? I as the privileged person who gets to run a nonprofit here in San Francisco, I'm directly linked to Dr. Colfax's updates, right? The general swath of the community is not linked into Dr. Colfax, right? They are not watching Facebook Lives from the mayor. And so the window for us being able to educate and get folks information that they can trust, I think relies on community leaders. And I think we need to meet people where they are, right? If I have a group of folks that are not connected digitally, then I have to be able to communicate with them in a way that is safe and in a way that best serves them without making them feel like they are less than.
Great, thank you. Thank you, Billy, sorry. I'd like to put this question to Brett and Ruth and perhaps Dr. Bennett as well. As we look at the history of the public-private partnership as well as nonprofit sectors coming from through the AIDS crisis and creating those structures that help to deliver outcomes to reduce the infection rates and improve health outcomes, what do you see are the important factors as we go through COVID to ensure that we have a sustained model that we can turn to because I do believe it is when the next pandemic comes upon us. Because I think that many, not necessarily in San Francisco because of how progressive and rooted we are, but many across the country, we put all of our tools away and then this came on and we were ill-equipped to respond. So what do you see both the lessons that were implied here and how we can sustain these going forward?
Well, thank you, John, for the question, and I'll also just say it from a nonprofit's perspective. And when I thought of COVID, and I've been reflecting on this, it was a moment in time, right? And so there's a pre-COVID San Francisco, and there's basically a post-COVID. And for me, I thought COVID really was a bit and remains a stress test of the current system and systems of care. That said, it's worth looking at it through the lens of some evaluation. How well was and coordinated was our system and systems of care, not only within the public health system, but in partnership with the nonprofit community providers. And I dare say, and this is, John, you alluded to it, we're doing pretty well. We fared pretty well. The system of care that we had, the network of service and service providers, both civil servants and nonprofit workers, along with some who are certainly responding from the private sector, I feel went a significant way towards the success that we are having. And that's why I tip my hat to our city leadership over the many years that has worked very hard to maintain that system of care. Where we have lost federal funds, the system has stepped forward and the city has stepped forward and added resources where we were losing federal resources. So there is just as there is a priority as we had with HIV of making sure that the system remained responsive to the emerging needs of the community. That is a page from the playbook that I know that we will take with COVID. So as Ayanna mentioned, the command center is not here for a day or a week or a month or 6 months, but the better part of a year, possibly longer, and may very well have to formalize itself as an extension of the Department of Public Health for, in perpetuity in many ways. And I know that the city is prepared and ready to do that because they have a roadmap to do that, just like we had an AIDS office that has existed for decades. And that speaks to the success that we are having in the community. So as much as the virus itself is unknown, I do believe our system of care is well designed enough that we can certainly build on the success that we have in terms of its infrastructure and its capacity, but also learn lessons from some of the mistakes that we've made in the past. I know Ayanna may have a few words to say about that too.
Thank you, Brett.
I would say if we didn't know it before, I think we knew a little bit how interdependent we were. We definitely know now because if we don't function, it cripples the private system. If the private system doesn't function, it cripples us. We each have a scope of work, and the degree to which we have to take on the others makes the whole system not work, right? So when this virus has really pushed all concepts of supply chain. I don't know what we're doing now, but whatever we thought supply chain was before, we didn't know what we were doing. And the system was not built to ramp up in these extreme ways and then go back down and then it's not built to do that. We're a steady state kind of place. And so knowing that those weaknesses exist, I know we all like to run lean, but we might need to, do something different. The degree to which we coordinated about our response was really beautiful. I mean, the coordination between the hospitals in San Francisco, I think, is a model for everywhere. They were, with that hospital council, the fact that we have had a joint community health assessment for years and years, having those systems in place, just as Brett said, left us something to lean on. But at the same time, that does not get everybody what they need, right? That doesn't make swabs or media or any of the things that people needed and didn't have show up. And so when those systems weren't able to support the people who did have means, those people came and flooded the system that was meant to take care of the people who didn't. So people who have insurance were using the city testing sites, which crowded out people who otherwise need. We actually started not advertising some of them, like let's do it in the neighborhood. Maybe the neighborhood will come, because we were getting everybody because they couldn't get it from their doctor because everybody was out of what they needed to do what they needed to do. So those weaknesses, I'm hoping we learn from, and that we coordinate at a higher level. We coordinate as a purchaser. We coordinate as a producer. Let's all go make swabs next time. Let's not do this. Let's all buy them and then sell them to, let's do something else so that we don't keep trying to use the system when it doesn't function, that we have another gear we can get into more quickly, because now we know that the system isn't going to ramp up in that way to meet something this heavy. And so we have a second year, because right now we didn't have that.
Great, thank you. And Ruth, what I'm going to do is ask you, we're going to have the last question is going to go to you, and you can also speak to the linkage. So we're really looking at linkage here, linkage between the public and private sectors, as well as the nonprofit sectors, which are what is going to drive the solutions, what is going to drive the healthier outcomes. We can't pivot and look to the private sector and look to Quest only, or the city, or PRC. It is this collaborative work effort, and that also fits into the San Francisco model. So Ruth, if you could speak to that, as well as, you know, there's been a number of panelists that have spoken to the misinformation and conspiracy theories that are out there, and that makes it an impediment to continuing to fight COVID. Where can you direct individuals who are on the attendees today to get that credible information, to get information that they can trust? So again, just as Quest does with its diagnostic services, can make healthy decisions for themselves and their family.
Yeah. So, I mean, having been involved with COVID from the beginning, you know, and with a pandemic or with a new virus, you don't, information changes, right? We don't know what we don't know. And in the beginning, what we thought in the beginning has changed over the past 6 or 7 months. In terms of where people can find credible information, I personally trust Dr. Fauci. You know, I think he has been spot on from the beginning. So in terms of credible information, he is definitely somebody that I find highly credible, and has never steered us wrong from that perspective. We also always direct people to the CDC, even though even lately on the CDC side, we've seen some strange decisions and reversals of those decisions happening as well. So I get it that it's challenging. I think we also always need to keep in mind that with a pandemic where everything is new, information also changes. So keeping keeping abreast of the latest is not always easy. So I would advise, listen to Dr. Fauci. There are a lot of organizations out there that have very good educational materials out there. American Heart is one example, and there are many out there as well that really make sure that we have the latest and greatest information. And of course, through Quest, we also try to make sure that we have the right information out there, not just on testing, but on COVID in general, and making sure that people take the right precautions as they, try to live their day-to-day lives.
Great. Thank you, Ruth.
Mm-hmm.
Before we wrap up, Ruth pitched me a softball. First of all, I want to thank all of the panelists for dedicating your time and sharing your experience and your knowledge and your passion. I feel, again, privileged to have been a part of the conversation and help to navigate this. And I hope that what this opens up for those that have attended is that opens up ongoing dialogue within your own community, with your own family, looking at this through the lens of what do we need to do as a community, but also what do we need to do as individuals? What are we responsible for? And how can we bring about those outcomes and impacts? And how can we be an example to those around us? As we look at going to the future, this is about not letting our guard down. I think there is so little information that is coming from a federal level that we can all trust, and so there's oftentimes the misinformation is guiding us, many in the wrong direction. So I think seeking the right information, as Ruth said, through Dr. Fauci, is a great place to start. Before I just close, I wanted to let everybody know, we'll send you information. The National AIDS Memorial holds an annual World AIDS Day observance. This year we will be holding a World AIDS Day National Observance virtually, and Quest is one of our partners. And we will be hosting a conversation between Dr. Anthony Fauci and Dr. David Ho, and that will take place on World AIDS Day from 10 a.m. until 12 noon. There will be two other tracks as well that we will be speaking to. One is the impact upon marginalized populations in communities of color and how systemic racism and the impact upon health outcomes, as well as how activism plays out in pandemics and epidemics and how it brings about meaningful change to the community. So I invite all of you to seek out information on that at aidsmemorial.org. Also, I want to invite anybody in our community in San Francisco who's in the Castro to please consider paying a visit to the Castro Country Club. The Castro Country Club is located at 405A 18th Street, just down from Castro and 18th. As Billy has said, it has been there for 40 years, and it has been providing life-sustaining services to those in the community that are changing their lives and moving away from substance abuse. And of course, at prcsf.org, you can find information that Brett has so greatly shared with us today around the wraparound services that are provided by PRC to the community. And lastly, I want to thank Dr. Ayanna Bennett for all the work that you're doing to bring about meaningful health within our community, to ensure that our community is healthier one individual at a time, and it is a matter of focusing on resources and where they are needed. And lastly, I cannot express the depth of appreciation to Quest Diagnostics for their leadership. I've had the great privilege of working with Quest for the better part of 4 or 5 years, and there are few organizations that understand what it means to be a community partner to the level and to the degree that Quest does. Quest, obviously supports a great deal of nonprofits financially, but they are most interested in ensuring that the health outcomes of individuals are sustained and improved, and thus the health of our community continues to be improved as well. So again, I want to thank Quest for all of their work, Patrick Pluman for your leadership, along with Jean-Marc Halbeau, and specifically I'd like to call out Samantha Landon for her help and leadership in this and making this all possible today. I will now, without any further ado, I will let everybody head off to a great weekend. We do see a little bit of blue sky out here today. So again, be safe, be the change you want to see in the world, and thank you all.
John, thank you very much. What a great facilitator. You have another career. I can see that. Ruth, you really know how to throw a softball. No, that's a softball. And John, I don't know.
One last thing. If everybody could wish Brett a very happy birthday. He's in Dallas for his birthday this weekend. So Brett, please go out and have a good time. And don't forget, just because you're in Texas, it doesn't mean the virus isn't there. Put your mask on, sweetheart.
I will put it. I got a few of them. I've got a few of them.
Happy birthday.
Take care, everybody. Thank you for
Thank you
joining.
all.
Really
All right.
appreciate it. Thank you.
Bye-bye.
Bye.
Bye.